Hi, everyone. Good morning. Today, we're joined by Dr. Stenehjem to give our COVID-19 update to the community on what's been happening in the state of Utah. Dr. Stenehjem, thanks so much for joining us. It's nice to see you.
Likewise.
I'm going to start with case trends as always and go over what's been happening. These numbers are reported from yesterday, just so everyone is aware. But yesterday's daily case counts was reported at 1,243, which is up 147 cases from that same day last week. We had a total of 3 deaths, and our hospitalizations sit at 388. Our 7-day percent positive rate for COVID-19 is 13.5. I want to talk about what we're seeing in our hospitals right now. Can you talk to us about the current situation in regards to capacity?
Yeah, we're in a pretty dire strait right now. So as of yesterday, our trauma COVID hospitals were at 102% capacity in ICU. And so that's staffed beds. So those are available beds that are staffed by clinicians, nurses, physicians, advanced practice practitioners, et cetera. And then we're at 102% capacity. Our floors, or acute medical surgical floors, are not far behind at about 98% capacity. So we're full, completely full. This is not a place that we want to be. 100% capacity is not where you want to run a hospital. That means that all the beds are full in the ICU. So when you get a trauma patient, when you get a MI patient, a heart attack patient, a stroke patient that needs an ICU bed, you got to figure something out. You have to figure out who can move from the ICU to the floor, who doesn't need to be there, and how do we get that patient up into the unit. So it is a position that is really taxing and stressful on our caregivers, both on the ICU and also the med-surg side, because what ends up happening is that you're taking care of sicker patients than you really should be on a general medical floor or surgical floor. And so, the summer months are still upon us, and I worry about all those people enjoying, the great outdoors in Utah with side-by-sides and mountain biking and rock climbing and accidents hitting our hospital and not having the resources or the space that they need, regardless if you're COVID or not. And so we're in a really tough spot, and everything is back on the table again. We have to think about how do we reduce the number of people in our hospitals. And so those discussions about delaying elective surgeries, all of those things that we did back last year, they're back on the table. And it's all in, looking at how do we ensure that the safety and quality of our care is the best we can provide it. But that's unfortunate because we know that elective surgeries aren't elective for those that need them. And so unfortunately, all those things are back on the table, and we'll, follow our capacity very, very closely and adjust as necessary.
Can you set the stage too to what the typical ICU capacity normally is? Not last year, but let's go back to 2019. What do we normally see for our percentages that we have in the ICU as well as acute care, like you were mentioning?
Yeah, I think what we should frame that more as what are we comfortable sitting at? Like, what is the optimal capacity of an ICU where we have those beds available to those that need them? That optimal capacity is 80-85%, where you've got designated beds and staffing to accommodate, a significant trauma or a significant surge and stroke and MI patients. And so that's where you really want to be, is in that 80-85% range. And so you've got that buffer to, temporarily go up to 90-95 and come back down. And so, that's really kind of our target. And the state has set some of those thresholds on the website to look at kind of where we're at. And we're obviously well over those at this point.
You mentioned this briefly at the very beginning, but how are our caregivers feeling? What is the strain like right now in the hospitals, and how are you feeling? I know you personally are dealing with this as well.
Yeah, so I was just on call for that infectious disease consult service just a week and a half ago, and I haven't seen morale this low in a hospital, and well, I don't think I've ever seen it this low, period. Our caregivers are really strained, and part of it is that we don't have the workforce to give people breaks. We're asking them to work more shifts now. we don't have that whole stable of redeployed caregivers. And so it is incredibly taxing on our caregivers. In addition, our hospitalists, our ICU doctors, and man, our nurses have taken such an emotional toll on this. And now seeing patients come in the hospital and that are suffering where they didn't need to be. The majority of patients that are coming into the hospital with active COVID-19 are not vaccinated, and they could have been vaccinated. And if they were vaccinated, the vast majority of these hospitalizations would have been avoided. And so seeing that so acutely of a preventable episode of suffering is just so wearing on our caregivers that, I worry about them in terms of what it's going to look like. And we're kind of staring down the barrel of a potentially really bad fall and winter without a whole lot of relief unless something changes. And so, I'm worried. I'm worried about our caregivers. I'm worried about their mental well-being. I'm worried about how they're going to, get through the fall and the summer. And it's a pretty trying time right now in the hospital. They're pretty low at this point. How am I doing? It's just kind of numb to it all at this point. And I speak for all of the infectious disease leaders, we've been in this fight now for over 18 months. And we all kind of thought that, man, we've got this effective vaccine that's safe and it's effective. And I think I had it in my mind that everybody's going to get it that can get it. And we wouldn't be in this situation. And that, and I think I even said it here on Facebook Live, that I think that the summer is going to look a lot better. And so it just kind of shows how we were wrong. And we're tired as well. We want to be able to kind of go back to some of the work that we had been doing that we were excited about in terms of improving infectious disease care across Utah, Idaho, and Nevada. But we're not. We're continuing to focus on COVID 100% of the time. And that's okay. We're going to keep doing that to the best of our ability. And we realize now that COVID is here to stay. And unless we can get our community fully vaccinated, we're going to be dealing with this for the indefinite future.
And if you could say anything to people watching too around how the public and the community can kind of help our caregivers and lift them up right now, what are some suggestions you have for people watching?
That part's really easy. They can prevent the transmission of COVID, period. Hard stop. How do we do that? We know how to do that. So we can wear masks, and we can limit our social interactions, and we can do social distancing. And we can get vaccinated. Those things are what we need the public to do. And, I sound like a broken record in the fact that that's exactly the same message minus the vaccine part that we were giving last summer as well. And so what you can do to thank a caregiver, thank a physician, thank a nurse, a respiratory tech, a physical therapist, is to get vaccinated. What you could really do is, if you're vaccinated, make sure your family's vaccinated. Make sure your friends are vaccinated. When you see messaging on social media that is wrong, that is not rooted in science, push back. Say that's not right. What we need to do is really mobilize our communities to step up and say, this is the right thing to do. This is safe. This is effective. And we need to do this for the community. So we love getting thank yous. That lifts us up. We love getting the pats on the back. Thank you for your service type things. What would be even better is if you went out and you encouraged your family, your friends to get vaccinated. You drove them to get vaccinated. You yourself got vaccinated. Wear a mask when you go into social settings. Limit your contacts. Go outside. That's what you can do to really lift us up at this point.
You mentioned this a little bit briefly around the people that are in our hospitals right now, vaccinated versus unvaccinated. Do you know the specific percentage between the two at all?
Yeah, so we monitor that pretty closely. We look at all patients admitted to our hospital with a positive COVID test within a pretty narrow time period. And we look at what proportion of them are vaccinated versus unvaccinated. And so there's a couple ways you can say this, but at this point, 90% of the COVID admissions are unvaccinated. 10% of those that are admitted for COVID are vaccinated. And so the vast majority of patients admitted with COVID are unvaccinated. When you look at and dig in specifically to the patients that are admitted to the hospital with COVID that have been vaccinated, it's pretty remarkable in the fact that many of these, I would actually say the majority of these, are people that we'd expect didn't generate a significant immune response to the vaccine. They may be immunocompromised from medications that they're taking. They may be immunocompromised from receiving a transplant and being on medications to lower their immune system. They may be people that have significant comorbid illnesses. And so those are the people that we're seeing that are vaccinated and are getting admitted to COVID. And that's, unfortunately, that's what we expected to see. We knew that the vaccine isn't 100%. In fact, that the data tells us that. And the people that we are seeing that have vaccine failures admitted to the hospital are ones that we'd expect to have vaccine failures in the setting that they didn't generate an immune response.
Is there a difference too between ICU percentages and just normal administrations to the hospital for vaccinated versus unvaccinated, or is that typically the same?
I don't have that distinct number right now. You know, when we review these vaccine failures, the majority of them are on the floor and not in the ICU. That's not 100%, but the majority are on the floor. And majority of them have done well in the fact that they get admitted and they go home. But I don't have the distinct numbers split between ICU and the floor.
I know you don't work at a pediatric hospital, but can you speak briefly to children and if there's been an increase at all in children being admitted to the hospital with ICU or with COVID? And if so, what that age range is falling out to be right now?
Yeah, I don't have the specific numbers for primary children's, but can speak from a national standpoint that we are definitely seeing an increase in children being admitted to the hospital and an increase in cases in children. And I think we have to anticipate that we're going to see more of that, unfortunately. The Delta variant is incredibly transmissible. And so as we have schools going back into session very, very shortly, and we don't have a mask, mandate or criteria for schools, we will see transmission in schools with this incredibly transmissible Delta variant. We'll see cases go up in children, and some of those children will have severe disease. And those children will end up in our hospitals, and we'll see those numbers most likely go up. I really hope that our communities recognize that masking is the right thing to do at this point in time for children when they go back to school, and that children are very good at this. We underestimated children in terms of the ability to mask, and they do very well with this. And there is not any documented, biologic adverse reactions to having masks. I mean, some kids don't like it. I definitely get that. But if we want to prevent transmission in our schools, we have to go back to the things that we know that work. And one of those things includes masking.
A question that we've gotten a lot too is around natural immunity as well. People who have had COVID-19, the actual virus in the past, and are maybe not vaccinated right now. Do we know anything about natural immunity and what that does to protect you versus the vaccine itself?
Yeah, so this is going to get a little technical. I apologize, but I think that's the only way that we can get into it. There's a number of studies now that have come out that have looked at what is the effect of natural infections or naturally generated immunity on reinfection, comparing that to those that have been vaccinated. There's a study that was released out of Cleveland Clinic. Pfizer released data on their actual study looking at the placebo patients that were seropositive and looking at that effect. And in those studies, we see that natural immunity is pretty solid, for at least 6 months. That's where we have those steady endpoints. The challenge we have with that is that, one, we don't know for how long. We don't know if that 6 months will be 12 months. We just don't have that data. And two is that we see that there's significant variation in the immune response after natural infection compared to that of immunity. Okay, so that's one point. The other really big point that we have to emphasize is that those studies that have looked at that stopped before the Delta variant has taken hold within the United States. And so what those studies show is that, yes, natural immunity works pretty well for the original ancestral strain of COVID-19 and also for Alpha. That was that first B.1.1.7 variant we saw coming from the UK, that it works pretty well for that. Now, we have a completely different variant. We have the Delta variant. And what we do not think is that we don't think that that natural immunity, that data that we have for those 6 months that have come from those different studies that have focused on the original strain and also Alpha, we don't think we can extrapolate that to Delta. Okay, so it's, does natural immunity have cross protection against all variants? Okay, so that's the key question. And I think a good example of this is what happened in Brazil. Okay, so in Brazil, they had a very significant outbreak with 85% of their population being infected. So this was that natural experiment of like what happens with herd immunity. And they had a terrible time, but they had a huge amount of people that were infected. Then fast forward about 6 to 9 months, and they had another huge outbreak with a new variant. Okay, and that variant caused significant illness in people that had previously been infected. So that example just shows that just because you have natural immunity against one variant doesn't mean that you're cross-protected against all variants, i.e. Delta variant for us. Okay, so then the question should be, well, how well does the vaccine work that was designed with that original spike protein? How well does that vaccine work against Delta, against our new variants, right? Because you have to ask the same question, natural immunity versus vaccine. And what we have seen now, and there's a number of studies that have come out, is that the vaccine does protect against Delta variant. Okay, so it protects well against Delta. And we have data now out of the UK, we have data now out of Scotland, Singapore, and Canada that shows that, you know, vaccination with Pfizer and Moderna, we don't have much data on J&J, protects against definitely severe disease and hospitalization when you get when you have a Delta virus circulating. And so that's the data we have. The data is vaccine works against Delta. We know that from all these vaccine effectiveness studies. What we don't know and what we suspect we'll see here soon is that prior infection isn't as protective against Delta as vaccination is. So sorry for that long-winded answer. It's really complex. We're following the science incredibly closely. And the recommendation right now is if you've previously been infected with COVID, get vaccinated. Because we know that vaccination is going to protect you against Delta. We don't know that natural infection is going to protect you against Delta. And the vaccine is safe and it's effective. And so get vaccinated.
I want to go back to children really fast and just address why you potentially think there is an increase of children getting more sick. Does it have to do with the Delta variant, or is something else changing within what's going on right now?
Yeah, it very well potentially could be due to Delta. We know Delta is more transmissible. We feel super comfortable in saying that. We also think that the Delta variant causes more severe disease, leading to hospitalizations, more need for oxygen, and the like. But we're also seeing it being more dominant in the younger age groups. And so, you know, it's really hard for us to definitively say that it causes more severe disease. We can definitively say it's more transmissible and that the age groups that it's affecting is different. Whether that the Delta, you know, for some reason targets the younger age groups for whatever biologic reason, maybe. We just know that the presentation is different and it's affecting different people and likely more severe disease. So, you know, it's kind of a wishy-washy answer, I'm sorry. But it very well could be to the Delta variant. And it also very well could be the fact that when you look at vaccination by age, more and more people are vaccinated as the age goes up. And so you've got a much more protected older population. So think of those people as non-susceptible. And so where is that virus going to find susceptible hosts? It's that younger population. So I think it's probably layered in the fact that we've got variable vaccination uptake based on age. You've got a new variant that may have new characteristics to it. I think all of that leads us to kind of the situation we're in.
And is there any way to look at a trajectory of what could potentially happen if we kind of continue on the road that we're on, if the vaccinations kind of stay at the rate that they're going? Do we have any sort of predictive model of what could happen this fall?
Yeah, I've got this crystal ball right here, so I'm just going to gaze into that, Amanda. You asked me to predict all the time, and I don't know, I'd be interested to go back and say, what's my record? So when we look at Delta surges that have occurred elsewhere in the world, the ones that you look at would be the UK and India. They had a really rapid onset and pretty rapid decline. India, keep in mind though, that was layered with significant public health interventions. And it was in a group where you had vaccines going up, but you didn't have a huge group of people vaccinated. Contrast that with the UK, that had certainly a lot more people vaccinated, but you had this rapid onset and rapid off, but also had some public health measures layered into there. So are we in Utah, are we in the US going to see a similar rapid rise and rapid fall? I'm not sure. We've got a pretty significant population that is vaccinated, which I don't know if people remember this idea of flattening the curve. We talked about that way back in like April and May. And the fact that what we want is to, flatten that epi curve, don't have that big spike where we're not having access to healthcare. That may very well be what's happening here in Utah and the US, is that what we may see is this kind of high plateau where we've got lots of people in the hospital, but we're not seeing this major spike. And if you look at the past 2 days in our epi curve in terms of number of cases, you're starting to see that. So I suspect, so I'll put my nickel down. I suspect that we're going to plateau a bit like this. I think schools are going to go back in. We're going to see transmission within schools that will lead to a small increase in pediatric hospitalizations and severe disease. But then we're going to start seeing transmission amongst families and communities that originate from children, and we'll see those numbers go up. That's, I think, kind of where a lot of us are kind of thinking we're going to go. But again, so hard to predict this in terms of changing public health measures, changing attitudes, mask mandates in schools, mask compliance in schools. It's really hard to predict. I think we're in this though for a bit. I don't think that we're going to have a rapid offset of cases.
I know last year too, we talked about the flu, and it's crazy that flu season is almost upon us. And I know that you guys look to Australia to see what they had last year and kind of compare it to what the US could expect. Do we know anything? And I know they are much more strict around what they're doing with COVID measures, so this might be a hard question, but do we have any expectations for what can happen with flu and even RSV this year and other types of respiratory viruses?
Yeah, it's going to be a really challenging diagnostic year. Okay, so what we're already seeing right now is we're seeing RSV. We don't see RSV. So RSV is a respiratory virus that predominantly affects children and can cause severe bronchiolitis, leading to hospitalization. And in adults, many times it's just a standard cold that you get. We don't have long-standing immunity against RSV. And we didn't see any of it, like zero RSV or flu last winter. And that was what we think multiple reasons, but one is people were masking, people were socially distancing, people got flu shots, and we didn't have that migration of influenza from the Southern Hemisphere to the Northern Hemisphere. We just didn't see anything. Now we're seeing RSV, we're seeing summer colds, we're seeing these things because people have taken off their masks and now they're, getting back together and interacting. And so we're seeing RSV. That is, to me, a signal that we are going to continue to see more respiratory viruses in our communities. And that is going to include RSV. It'll include influenza. It's going to include human metapneumovirus and rhinovirus and all the other respiratory viruses. And so as opposed to last year, where if somebody came in with a respiratory infection, you assumed it was COVID, just because that was the only respiratory virus that was circulating. Coming now, if you have a respiratory infection, that could be COVID, could be RSV, it could be any number of respiratory viruses. We haven't seen influenza yet, but I expect that we will see influenza, this coming fall, and I suspect that we'll see that it'll be causing disease in our patients. And what do I mean? It's going to be a hard diagnostic year is the fact that when somebody comes in with a syndrome that could be consistent with COVID or flu, it's imperative for us to make the right diagnosis. If you can diagnose somebody early with either COVID or flu, you can offer them therapies. So with influenza, if you get diagnosed early, you can take oral Tamiflu and you can alter the course of influenza. If you get diagnosed early with COVID, you can get a monoclonal antibody if you meet requirements. And so it's going to be really important for those people that come in to make sure that we have appropriate diagnostics for them. And in children, it's important to know whether or not they have RSV, if they need treatment. So it's going to be an interesting year from a diagnostic standpoint to make sure that our urgent cares, our family practice, our pediatric clinics, our internal medicine clinics all have access to good diagnostics that differentiate between flu and COVID.
Can you talk a little bit more about monoclonal antibodies as well, and what someone needs to have or be to qualify to receive that treatment? I know we did a press conference about that earlier this week, but will you break that down a little bit more for us?
Yeah, for sure. So what is a monoclonal antibody cocktail? These are preformed antibodies against COVID-19, specifically against the spike protein of COVID-19. So instead of your body generating antibodies through a vaccination to protect you from getting COVID, what monoclonal antibodies are is when somebody gets COVID, we can give them these antibodies, which can then alter the course of COVID-19. And so it's an infusion of preformed monoclonal antibodies. And so these are really important, especially in individuals that are high risk to go on to hospitalization. So the ideal situation is you get symptoms of COVID-19, you immediately get tested. And if you test positive and are at high risk for a severe complication of COVID-19, you go and get an infusion of monoclonal antibodies. When that happens in that population, we can reduce hospitalizations by over 57%. Okay, so that's huge. And so what does that do to us? That minimizes the need for beds in the hospitals. And so we've got room for other people that weren't eligible for monoclonal antibodies. And so it's imperative that if somebody gets diagnosed with COVID-19, that they make sure that their medical clinician, APP, physician, whoever it may be, is aware of their diagnosis and evaluates them for monoclonal antibodies. The state has criteria in terms of who should get a monoclonal antibodies, and it's really dependent on your risk factors. And it's also dependent on whether you've been vaccinated or unvaccinated. So if you're an unvaccinated individual, your score you have to get is a 5.5, and you can then go on and get monoclonal antibodies. If you are vaccinated, just being vaccinated by itself is protective against hospitalization. So you need a higher risk score to get monoclonal antibodies, because we're really focused on utilizing these to prevent hospitalization. This is not to replace vaccination. We do not have the amount of drug or the ability to infuse these drugs across our system to be able to use this as an alternative to vaccination. This is adjunctive, and we hope that for the most high risk patients, we can offer this therapy. to potentially reduce hospitalization and then reduce death. But it's a very good therapy. Multiple studies have shown its benefit. Dr. Webb just presented his data that was recently published. And so it's just imperative for all of us, patients and clinicians, to know about this and be able to ensure that patients have access to it if they qualify.
I think your emphasis of make sure you still get vaccinated is very important on that too. Another question really quick on the vaccine, and just a clarifying question around natural immunity with the Delta variant. Someone asked, why would the vaccine be more effective in fighting off Delta variant versus a natural infection? Wouldn't you have a higher or equal viral load from natural infection?
So there's, I think, a couple of things into that question. One is the viral load bit, but we'll go back to the first one, is why would you have better protection with the vaccine against Delta versus natural immunity? I think there's a couple things into that. One, with vaccination, we know that you get both a B cell response and a T cell response, and you get that very reliably to a relatively conserved domain of the spike protein. And so we don't think that that immune response that you're generated from a vaccine, which is quite reliable among patients that are not immunocompromised, provides a broader neutralization of viral variants. Okay, so that's really the precedent of why we think that, or why we know that the vaccination actually provides, good response or good coverage to the Delta variant, versus the natural immunity, which has that variable kind of stimulation of the immune system. And I mean, I want to be totally transparent. We just don't have data on whether or not natural immunity is protective against Delta. Okay, so this is just something we are in a data-free zone at this point, but we need to look at those places that have had similar situations, that have had onset of a new viral variant that has superseded natural immunity. I mean, the Brazilian example is a good one. So it more is the fact that we know that vaccines offer good coverage to Delta. We do not know if natural immunity offers good coverage to Delta. We suspect that it's going to be less, but we just don't have good data on that.
Last question for you, potentially. I want to talk about our visitor guidelines. We've had these in place for over a year now. They've kind of changed as the pandemic has developed and everything has kind of, as we've learned what is going on, they're changing again today. Can you just give us a brief overview of a couple of those changes? And I'll post the link for everyone to look at those as well.
Yeah, I think, they're complicated guidelines and with a lot of detail. And so, Amanda, I appreciate you posting the link to the in-depth details. I would also emphasize, not necessarily in the visitor's guideline, but I would also emphasize the fact that any visitor coming into our hospital that are seeing loved ones and friends and family needs to be masked, even when you're engaging with that patient. We have had episodes where visitors have come to visit patients that are post-operative, whatever it might be, and have transmitted COVID to our patients. And so they've come in, they visited, the masks came off, and they've transmitted COVID from themselves to the patient who is in the hospital for a reason, recovering from whatever. And so it's imperative that all visitors that are coming in, regardless if you have symptoms or no symptoms, you shouldn't be coming in if you have symptoms, wear a mask, period. Now, in terms of the changes to the visitor guidelines, thanks for posting those again. I think the biggest difference is that we are limiting visitation to 2 individuals per patient in the hospital. And those 2 individuals need to remain the same for each 24-hour period. And so right now it's any 2 at any time. Now we're moving to a little more restrictive, where it's going to be you designate 2 individuals for each 24-hour period that they're there. And then there's some subtleties which people can refer to the document on.
Yes, that's great information. And I just posted those for people to look at. And Dr. Stenehjem was mentioning our hospital-based ER care. I just want to clarify that. There is a slight difference with ambulatory same-day surgery, and those details are in the link that I posted, and those are in effect as of today, just so everyone is aware. So if you are planning to go to the hospital, please make sure you look at those and also wear a mask as well. Eddie, is there anything else you want to mention to us today before we take off?
Yeah, I mean, we're back in the throes of this. When we look at our hospital capacity, our hospital volumes, we're back like we were in November and December. And the difference is that we have tools that prevent this type of thing. And that tool is vaccination. And that is the one thing everybody can do to lessen the load on our hospitals and on our caregivers and on our communities. And so vaccination is safe, it's effective, it remains effective against the Delta variant. And it's imperative that people go out and get vaccinated. We're not at the level where we should be. We know that vaccines work at a population level. And if you look at the states with the highest vaccination rate compared to the states with the lowest vaccination rate, there's an incredible discrepancy in hospitalizations and deaths. Those with the highest vaccination rates have the lowest number of hospitalizations and the lowest number of deaths. It's very clear the effect of vaccination. And Utah needs to become one of those states that have very high vaccination rates, because that's going to protect our communities. It's going to allow our kids to go back to school. It's going to allow us to, maintain some normalcy. We had a period of normalcy, I feel like, early in the summer, and now, unfortunately, that's gone. So, my request is that if you haven't been vaccinated, get vaccinated. If you haven't been vaccinated and you have questions, ask your doctor, ask your physician assistant, ask your nurse practitioner, ask your friendly nurse, who just get the information you need and make sure you're getting it from a reliable source. And then it's also imperative that we all put our masks back on. If you're going indoors, mask up. It's easy, it's simple, it doesn't take anything. It isn't a symbol of anything, it's a symbol of safety. So please put your mask on, wash your hands, and again, try to limit your indoor gatherings where you're seeing a number of people that you don't know what their risk profile is. And so unfortunately, we're back to those precautions that we were at. And we really need to get this under control before we get into that winter season. We know what happens in the winter and the holidays, and we just aren't going to be able to sustain the stress on our healthcare environment that long. So that's my continued request, continued plea to people. And thanks, Amanda, for the opportunity to get that out.
Of course, and thank you for everything you're doing, as well as everyone else. And if anyone is watching, wants more information about the COVID vaccine, they can go to intermountainhealthcare.org/COVID vaccine. There's also the state's website, coronavirus.utah.gov, that has a lot of great information as well. And if you have any questions and we didn't get to them today, we'll go through and answer those afterwards. Again, Dr. Stenehjem, thank you so much, and we'll talk to you later.
Thanks, Amanda.